Welcome back to Diabetic Foot Files, the podcast where we break down the science, decision making, and real life complexity behind diabetic foot disease and limb salvage. Today, we're going to talk about not a technicality, but it means a lot when it comes to surgical intervention in diabetic limb salvage and its surgical margins. Because you'll ask, like, how are the margins, right? After the pathology report. And what are they? Why do they matter so much in amputations and wound surgery? Why do two patients with the same amputation sometimes have completely different outcomes? And it actually does matter when it comes to surgical margins. So, a patient undergoes a toe amputation for diabetic foot infection. The surgery looks clean, the wound is closed, the infection seems controlled. But a few days later, the pathology report comes back with one line that changes everything: positive margins for acute osteomyelitis. So, then the question is, did we remove the right amount, right? Should we remove the toe? More of the toe, pretty much. Did we remove enough? And that's a question that happens if I ever see that. So, what are surgical margins? So, surgical margins are the edges of what was removed during surgery. So think of it like this. When a surgeon removes the infected tissue, please get all of it as much as possible. They are not just removing the visible problem, they are trying to remove the entire zone of disease. And so we evaluate the center of the specimen, often the most damaged area, and then cut the edge where the body was left behind. So the cut edge is the margin. So, in simple terms, a negative margin is a clean edge. There's no sign of infection or disease seen at that cut border. If it's a positive surgical margin, that means there is still disease at the edge. So, infection or pathology still extends right up to where the surgery, excision stopped. So, the relationship between surgical margin status and recurrence is one of quite strong predictor of the success of a diabetic foot surgery, particularly in cases with osteomyelitis, chronic ulceration, and limb salvage procedures. However, recurrence rate also vary and depend on other different things like we're discussing bone infection, if it's just soft tissue infection, tumors, wound recurrence, because for diabetic foot surgery, the best data comes from diabetic foot osteomyelitis, which is affects a lot of diabetic patients. And that's something that we all try to avoid for our patients to happen. But when it's osteomyelitis, it is surgical excision of that part of the bone is mostly recommended because, like I always tell people, think of fossils. They are able to find fossils of bone years, centuries from now, right? But osteomyelitis eats away at the entire bone. So think of how strong that is and what it will do. And do you want something like that continuously, not just in your body, but antibiotics can get it to sleep and calm down. But if we don't remove it, this thing is going to come back and eat more of your bone. So, when it comes to negative surgical margin, that means there's no residual infected bone. And studies generally report recurrence rate of osteomyelitis approximately 5 to 20% if there's negative surgical margin. So that's saying like pathology report says there's the negative surgical margins are there's no sign of osteo, right? Need for surgical additional surgery is usually 10 to 25%, limb salvage 80, 95%, and healing rates are usually 75 to 95% when you have negative surgical margins. So that's really good. And several studies have shown healing rates above 85% when the infected bone is completely excised. And I want patients to understand that because that's why they're suggesting possible toe amputation or excision of this part of the bone is because your rate of recurrence is extremely low and your rate of healing is extremely high if we remove all the infected bone. Positive surgical margins. So that means that there is residual infection there, okay, in the bone. And the recurrence rate is up to 30 to 60%. And some studies show or report approaching 70% in poorly controlled patients who have diabetes, right? If their diabetes is poorly controlled. And there's definitely going to be increased need. If you have positive surgical margins, there's going to be increased need for repeat debridement, higher level of amputation, prolonged antibiotics, delayed wound healing. forgive me, delayed wound healing, and positive margins are consistently associated with worse outcomes. So it is an issue if we see that. So certain selected literature shows that, Aragon and Sanchez, that's a lecture published article, found that patients with clean bone margins experience significantly fewer recurrent infections, faster healing, and lower reoperation rates. And residual osteomyelitis at the margins increase complications substantially. And another one, Kowalski, published an article and it compared positive versus negative bone cultures from surgical margins, and patients with positive surgical margins demonstrated higher recurrence rate, longer antibiotic courses, and greater risk of proximal amputation. And usually ID needs to see that as well because that gives them an idea of your antibiotic course after you get discharged, right? Because they have a better idea if you still have positive surgical margins, yeah, there's still residual infection in there. So why does positive margins matter? We went a little bit about this, but residual infected bone continues to contain the problem. So the biofilm, the necrotic lunar bone or the infected bone, avascular tissues there, inflammatory cytokines, bacterial reservoirs. Remember, think of everybody's had a cold and a snotty nose, right? Think of that snotty nose and all that mucus and dripping, that's in the bone, and that's still in the bone. It never fully dries up, okay? And antibiotics penetrate poorly because, diabetic bone often has poor perfusion, microvascular disease, as well as impaired immune response. So even if the wound initially closes, the infection may persist microscopically and then recur months later. So margins do matter in our diabetic foot surgery. So in diabetic foot care, margins are not just academic, they're predictive. So one of the critical questions is, did we remove all the infected bone or did we stop too early? And sometimes that's kind of like a weight that surgeons have to go through because you want to not compromise with the patient, but you wanna have the same expectations. Patients will be there, "I don't want any more of my toe removed," you know? And they's like, "I just want this part," but you have to explain to the patient, if you go a little bit further, that increases your chances of not having it recur back, right? But patients have to understand the severity of a bone infection, because diabetic foot disease is rarely surface level. I mean, anybody can tell now, but it does involve deep tissue, tendon, bone, microvascular compromise. So if infection is still present at the margin, at the surgical margin, the disease may still be active in the body. And we already talked about the clinical impact that negative margins have: lower recurrence rates, shorter antibiotic course quite often, higher likelihood of healing, and reduced need for reoperation. Positive margins mean you have a high risk of persistent infection, increases your likelihood of having a reamputation, and prolonged antibiotic course and delayed wound healing. So, what do pathologists actually do? So, once the specimen reaches pathology, right? Because we already know we're supposed to send it to pathology. It's not just looked at, it's actually processed. And there's what happens. So, there is the gross examination that goes on. The pathologist visually inspects the bone, the soft tissue viability, the necrosis, the abscess formation. Then there is sectioning. The specimen is sliced to expose the internal structures and margins are carefully identified. The microscopic analysis, so they make the slides, the microscopic slides, and examine it underneath the microscope, and they look for bacteria, inflammatory cells, bone destruction, necrotic tissue, and then the margins are assessed. Is there the disease still present at the edge of what was removed? So why are surgical margins so hard in diabetic foot surgery? So where margins are quite predictable in diabetic foot surgery, it's quite messy because the infection does not, especially diabetic foot infections, they do not respect boundaries. They do not respect borders. Osteomyelitis does not respect almost anything. They're quite fierce. I mean, honestly, if it can eat away a bone, what else can it eat at, right? But You often have patchy osteomyelitis, ischemic bone that looks viable, but it's not, biofilm bacteria hiding in the tissue planes, poor perfusion affecting the healing boundaries. So a surgeon may believe that they're cutting into healthy bleeding tissue, right? But on a microscopic level, it may still be present in infection. So let's do a toe amputation versus a transmetatarsal amputation margins, right? So a toe amputation, the margins may involve, let's make it very, very simple, proximal phalanx and a metatarsal head, right? And if the osteomyelitis is present in the metatarsal head, a simple amputation of the toe is not enough, right? You're going to partially do a partial ray amputation, most likely, to get partial into the shaft where you can have good, clean margins, right? Transmetatarsal amputation. This is more complex. So remember, got to do a TAL, in my opinion. Okay. So remember that TAL, adjunctive procedure, TMA. Okay. So margins become quite complex. Multiple metatarsal shafts, so you have to remember that. Soft tissue envelope, and then you also have to think about the weight bearing mechanics. That's why TAL plays a huge role. And if there's still positive margins, right, you can have a huge breakdown of the surgical site. You usually are able to tell quite quickly because one thing about infection and wounds, they do not lie. They love to open up if there's something still left inside of them. There's a quite progressive of the disease and there's a higher level of amputation risk. Now, why does clean looking doesn't always mean clean margins? This is one of the most important clinical misunderstandings. A wound can look clean, dry, closed, and non-infected, but still have residual microscopic osteomyelitis, deep bacterial colonization, and inflammatory bone changes. And this is why pathology, sending it to pathology is not just important, but critical because it confirms what the eyes cannot see. How do margins change the treatment? Like I said, if the margins are negative, most likely they're going to have a shorter course of antibiotics, routine wound care, and standard follow up. If the margins are positive, infectious disease definitely has to be on there, extended antibiotic course, imaging reassessment, consideration of revision surgery, and closer surveillance. So, how do we achieve the best negative surgical margin? So, one is perioperative imaging. So, MRI remains the best modality for defining the extent of osteomyelitis. I mean, bone biopsy, but you'll be able to see the entire foot, right? And see how it's affecting the entire foot, how far the osteo is extended. So these are useful adjuncts that include CT for cortical destruction. We can use tagged white blood cells, right? And then we can use a PET scan or a CT when there's availability. And then, okay, so what about when we remove the bone until it looks healthy? So healthy bones should appear hard. So you should touch it or tap it. Bleeding, so like the paprika sign, and we're not talking about verruca, we're talking about the bone, like the trabecular of the bone. White ivory cortex and intact architecture. You're able to see, okay? What I would use is a curette or a hemostat. Tap, tap, tap. Look, make sure it's bleeding. Paprika. Avoid stopping simply because the bone looks better. Let's think about all of that because there are consequences. Send the proximal bone margin. So many limb salvage surgeons routinely submit proximal bone margin. So the histopathology, the anaerobic culture, the aerobic culture, and this confirms whether the remaining bone is free of infection. Excision of all non-viable soft tissue, that is key factor when it comes to limb salvage and diabetic foot ulcers. Remaining necrotic tissue is only going to seed bacteria back into the bone and into the soft tissue. It will definitely impair healing and increase the rate of recurrence. One thing about it is I always tell patients it's really hard for bone to heal over not bone, skin to heal over infected bone. It's quite hard. That's why you're having this recurrence. Wait, I'm like, did they say that you had osteomyelitis? Yeah. I keep on getting this ulcer at this area. Most likely because you have osteo and it really doesn't like skin healing over it. Bacteria is quite a powerful thing, organism. I think they existed before us, so possibly. I think they did, yeah. So, evaluation of the patient's perfusion. So, negative margins cannot heal if the blood supply is inadequate. That's why we say vascular 3 times. ABIs with caution with diabetics because we know the false elevation, toe pressures, transcutaneous oxygen pressure, skin perfusion pressure, as well as vascular consultation. I would just get vascular all the time, honestly. Then offloading. Even the perfect surgery fails if there's excessive pressure because that would cause the wound to break down. So options include total contact casting, cambu, custom orthotics, and diabetic foot care and footwear, I mean. And optimization and glycemic control. So hyperglycemia, we already know it affects the neutrophil function, the collagen synthesis, the angiogenesis. Better glycemic control is associated with lower infection recurrence and improved healing. Now, also the biofilm. Everybody's been talking about biofilm. Biofilm is a big thing now these days. Mechanical debridement is a primary method of disrupting biofilm. Okay, I get correct. Curettage it. Yeah. Adjunctive strategies may include appropriate wound cleansing, topical antiseptics, culture directed antibiotics when indicated. Now, minimizing the dead space. So there's going to be residual cavities because you remove the part of the body inside or bone, okay? And residual cavities increase the risk of fluid accumulation. We know hematoma, seroma, most likely is going to be hematoma. Those are quite common. Recurrent infection and strategies include layered closure when appropriate, local tissue flaps, and negative wound pressure for selected wounds. And then you have to confirm mechanical stability. So residual instability or abnormal pressure can lead to recurrent ulceration, in new infection, and repeated surgery. So correct the deformity when feasible to reduce the recurrence. And factors associated with increased risk of positive margins are extensive charcot neuroarthropy, longstanding ulcers that have been there for greater than 6 weeks, peripheral arterial disease, poor glycemic control, large plantar ulcers, sinus tract, multiple previous surgeries, renal failure, as well as immunosuppression and delayed presentation. And also, we have to think about the emotional impact, okay, of telling a patient, hey, your pathology report came back, the margins, surgical margins are still positive. You have to make the patient understand what that actually means. It might mean another surgery, it might mean you need more time in the hospital, possible loss of mobility, and there's increased risk, a high risk of higher level amputation. And for most patients, they feel like, okay, you already did surgery on me. Why is it still positive? I already lost a toe. Why isn't this over? You have to think about it in the patient's perspective, okay? And for clinicians, we have to highlight the difficult truth. Sometimes surgery is the beginning of a control and not the end of the disease. And in diabetic foot surgery, what we leave behind actually matters just as much as how much we remove, okay? So let's do a quick, like, what would you do clinical scenario? So toe amputation is done. Pathology report came back positive bone margins, and the wound looks clinically clean. Do you treat with antibiotics or return the patient to the OR for revision or monitor closely? What would you do? And then another one, let's do patient is medically fragile, positive margins present, but surgery is risk high. The surgery risk is quite high. Do we accept the residual infection with antibiotics, attempt further surgery? I definitely would get ID if it was me. Shift to palliation focused wound care. We're gonna have to figure that one out because I one thing about me, I never give up on patients. I don't care if somebody says, "Oh, this is what they say this is needs to be amputated. There's no way you could heal." I'm like, whatever. I'm just like, let the patient decide and let's see what we can do. And honestly, when it comes to limb salvage, patients are fully aware that this is like a last resort attempt before possible amputation if they are deciding to do this and they don't want to lose their limb. They're fully aware, and I make them fully understand, hey, even through this process, you could possibly, it can go left and you possibly have to lose your leg, okay? But they're more than willing to if they understand what's going on. And like I said, I feel like they're like the most compliant. If they hear that they're going to lose their leg, I feel like they're very compliant. I never had a non compliant patient when it comes to that. They're, like, always there on time, they're coming, okay? I have another story about non-compliance, but that's for another day. Let's say negative margins are reported and the wound continues to deteriorate clinically. If I saw that, I definitely would think that there's still infection left in there. And I would want to go back. I would get another imaging, right? And figure out what's going on. But if the margins claim that they're negative and the wound keeps on deteriorating, something else is going on. Okay. The body does not lie. So many diabetic foot surgeons do aim to resect until they encounter healthy bleeding, structurally intact bone, and then send that proximal bone margin to histopathology and culture. And this combines the surgeon's intraoperative assessment with laboratory confirmation that the infected bone has been fully removed. Okay. But the key takeaways of this episode is that surgical margins represent the boundary between removed and retained tissue. In diabetic foot surgery, margins are very critical predictors of outcome. Positive margins suggest there is still residual disease or infection there and the risk is higher. Negative margins improve healing probability but does not guarantee success. Just like that situation, negative margins, but the wound keeps on deteriorating, something else is there and wrong, okay? We have to investigate further, re-imaging, we're probably going to have to open it up. That's my opinion, okay? But definitely, I would not do surgery unless there is vascular evaluation and clearance, okay? Unless it's emergency. Clinical appearance and pathology findings are both considered, and then margin interpretation directly affects antibiotics, reoperation, and prognosis, okay? So, negative surgical margins reduce recurrence by roughly 2 to 4-fold compared to positive margins, while exact rates may vary depending on the patient population, the surgical technique, but recurrence after complete resection is commonly reported around 5 to 20, where recurrence with residual infected bone is about greater than around 60% or higher. So achieving the best chance of negative surgical margins depends on careful perioperative planning. That's why it's good to discuss with the patient, saying that you might have to go further beyond. I like to go further beyond, okay, because one thing has happened and everybody's learned that if you don't and you try to be conservative and try to save as much as possible, the infection will come back. The skin will not heal over infected infection. It will never do that, okay? And we have to achieve the best chance for the patient, okay? And optimization of their systemic factors such as glycemic control. But even with negative margins, ongoing surveillance is quite important because the patient has diabetic neuropathy, there is vascular disease, there's foot deformities that continue to place the patient at a higher risk of new infection and ulcers. So, in closing, surgical margins may appear technical pathology term, but in diabetic foot care and limb salvage, this represents something incredibly bigger than what it seems. It represents the difference between healing and recurrence, stability and progression, and limb salvage and further amputation. Every millimeter matters. So even in limb salvage, we're not just removing the disease. We're just trying to decide where the disease ends, if the patient can save their limb, if the infection can recur. You know, just it's like letting we don't want to let any more bad tissue continue to infect the good tissue. That's pretty much it. Okay. But sometimes the line is not clear, and that's the whole point of sending it off to pathology. So thank you for listening to Diabetic Foot Files. I'm Dr. G. Yay, Independence Day is approaching. Happy July 4th. And take care of your feet because they take care of you.